This is what happens after. This is what might happen in the MDT, where you make a decision for mucosal, submucosal resection, or you make a decision for surgery, or you make a decision for something else. And this is the side of minimally invasive therapy, which we go into more here. So you have these options. You have EMR, you have ESD, you have the different risk profile of those. You have the fact that RFA, radiofrequency ablation, or cryoablation in its more, almost not really much evidence, but some coming up form, is pretty effective. And how does that fit in? And you have recurrence of cancer, dysplasia after the other therapies, and how can they be treated? So, key point number one, very nicely made. If you see something in Barrett's esophagus, is what I was saying, and Lopka and I were having a discussion about something flat, is there a disordered vascular pattern? I'm always resecting. I was trained like that.
I agree with that.
Okay. Anyway, well, whether you do or not, I think there are a lot of people that agree with the point of view I thought you were making, which is that can be RFA.
No, if it's flat and you see nothing.
Yeah, but it's flat and you see a disordered pattern.
Yeah.
So I'm okay. So clear message there then from both of us. Invisible lesions, you need to resect it. And then ESD, it's not easy, and Barrett's even less because of the doubled muscularis mucosa and the real inability to suck that in and really get a prediction of how deep you go. And ESD. What is the difference between them? That EMR is easier. I would argue that it is definitely easier. I mean, ESD and Barrett's is the most difficult kind of ESD, I would say. EMR is widely available. I guess it probably is. ESD is resource intensive. EMR is piecemeal technique necessarily. You've seen it. It took me 5 pieces to take that thing out. With ESD, we could have easily taken this out in 1 piece. One of the big advantages of endoscopic resection is not just the fact the patient can get treated by it, but it's also, it can give a microscopic diagnosis of the problem and the need for further therapy, the risk of lymph node metastases, the need for extra surgery or extra chemotherapy. Other treatments can be determined by endoscopic resection. So how do we grade it? Well, we grade it via the ones which are in the mucosa, the ones which enter the submucosa, and the depth at which they enter the submucosa. So really the important ones are these, and this red line is the important distinction between submucosally invasive, deeply submucosally invasive lesions and those which stay in the superficial submucosa or are in the muscle, the muscularis mucosa or the mucosa.